Pulmonary tuberculosis. Caused of organism, we have typical mycobacteria and atypical mycobacteria. Typical mycobacteria, Mycobacterium tuberculosis, it causes most of the cases. Mycobacterium bovis, endemic in cattle, spread in man through infected milk, causing gastrointestinal tuberculosis. Atypical mycobacterium, non-tuberculous mycobacterium, such as Mycobacterium marinum, Kansasi, and avian. It's common in immunocompromised patients, occasionally produce pulmonary or lymph node diseases. High risk. Age. Infection may occur at any age, but it's most significant at the extremities of age. Race. More in Negroes. I'm not racist. Environmental. Contacts with TB cases and those living in overcrowded and substandard housing. Immunocompromised patients, diabetes mellitus, malnutrition, and HIV. Habits. Smoking and alcoholism. Source of infection. Human source and animal source. Animal source such as milk, as we heard in Mycobacterium bovis, and human source we have mother to fetus through placenta and airborne droplet infection, productive cough. A bout of coughing produces about 3,500 droplet nuclei, which equate speaking for 5 minutes in a normal tone. Pathology of TB. TB affects any organ in the body, but most frequently it involves the lung. But we have organs resistant to develop TB, such as cardiac muscles, skeletal muscles, thyroid gland, and pancreas. Pulmonary TB may be primary TB or secondary TB. Primary TB, childhood TB, or the first exposure. After entry into the lung, the organism is ingested by alveolar macrophages. Some macrophages are unsuccessful in destroying the bacilli, so they remain dormant within the macrophage and may travel via pulmonary lymphatics or escape into bloodstream. The first infection is known as primary tuberculosis, and it's usually subpleural, often in the mid or upper zones. And the components of the primary complex is Gons, focus, TB granuloma, lymphangitis, and lymphadenitis in the draining lymph node. TB granuloma consists of a central area of necrotic material of cheesy nature called caseation, surrounded by epithelioid cells, Langerhans giant cells, with multiple nuclei. Lymphocytes are present, and there is a varying degree of fibrosis. The fate of the primary complex, healing, it heals completely and may become calcified. It's known that at least 20% of those calcified primary lesions contain tubercle bacilli capable of being activated again by depression of the host defense system. Or progressive primary TB in the setting of acute infection in immunocompromised patients. Secondary TB or post-primary TB due to one of the following: reactivation of healed primary focus, reinfection, or hematogenous spread. The secondary TB is generally found in the upper lung zones due to high ventilation perfusion ratio, as TB bacilli are aerobic organisms. Fate of the post-primary TB: fibrotic type, cavitary fibrocaseous TB, TB bronchopneumonia, and miliary TB. Fibrotic TB, small lesion that pass rapidly to fibrosis. It occurs with small dose of bacilli and high immunity. Clinical picture. TB presents with any or no symptoms or with any or no signs. Symptoms. The clinical picture of primary TB is asymptomatic in most cases. Cough may occur and mimics whooping cough. Productive cough and hemoptysis may occur. Hypersensitivity such as erythema nodosum, conjunctivitis, pleural effusion. Persistent collapse followed by bronchiectasis of middle loop, called Brock's syndrome. Manifestations of progressive primary TB. We have enlarged Gons focus, such as TB pneumonia or cavitation, enlarged lymph node, causing mediastinal syndrome or collapse, and lymph node rupture into pleural, causing pleurisy, and blood vessels causing miliary TB. Clinical picture of post-primary TB. Asymptomatic, discovered accidentally. We have general symptoms such as loss of weight, loss of appetite, night fever, night sweat. Chronic cough is the most common pulmonary symptom. It may be dry at first, but typically becomes productive as disease progresses. Hemoptysis is common, especially with cavitary disease, such as bronchiectasis. Most hemoptysis is small volume. Dyspnea and wheezes may occur, and finally chest pain. Signs. They are mostly non-specific, but general signs are fever, typically occurring at the evening, tachypnea, tachycardia, cachexia in advanced cases, and clubbing, which can occur in cases complicated with suppurative lung syndrome. Local signs: examination may be normal, lymphadenopathy, usually cervical, crepitations, Signs of cavitation, consolidation, pleural effusion, fibrosis, or collapse may be found. Look for evidence of extrapulmonary diseases such as skin, joints, CNS, and retina. Complications: pleural TB, bronchiectasis, middle loop syndrome, bronchiectasis sicca hemorrhagica, pulmonary fibrosis, TB laryngitis, amyloidosis, respiratory failure, cor pulmonale, mycetoma, aspergilloma, fungus infection with tuberculous cavity, massive hemoptysis, which can be rare, but it's most common with consequent bronchiectasis formation or due to rupture of malformed vessels in the wall of mycetoma cavity. Miliary TB, rupture of caseous focus into a blood vessel may result in formation of multiple tuberculosis foci from 1 to 5 mm in diameter in the lung and other organs of the body. It presents as fever, loss of weight, TB, meningitis, hepatosplenomegaly, and choroid tubercle in the eye. Investigations: TB is a clinical possibility, radiological probability, and bacteriological certainty. Radiology: chest X-ray. The usual location is in the apical lung. Patchy shadowing in one apex or both. Persistence of abnormal shadows for several weeks with treatment other than anti-TB drugs. Radiological signs of complications: cavity, consolidation, collapse, calcification, fibrosis, lymph node enlargement, hilar or paratracheal lymph nodes, pleural effusion, miliary shadows, diffuse small nodular densities. The value of radiology in TB: it's an early detection of TB and the extent of TB. Minimal lesions show no cavitation, moderate and advanced lesions show total diameter of cavitations less than 4 cm, and advanced lesions show more extensive than the moderate advanced lesions. Bacteriological examination: the gold standard for diagnosis. Zillnersen stain and culture on Liechtenstein-Jensen media required for definitive diagnosis. 3 consecutive morning sputum specimens are advised. PCR provides diagnosis within 2 days, 48 hours. Isolation of the organism from bronchial lavage, gastric aspirate in children, CSF urine, and sputum, and it can be induced by nebulized hypertonic saline in cases with scanty sputum production. Tuberculin test: 0.1 milliliter of purified protein derivative, PPD, containing 5 tuberculin units is injected intradermally. After 72 hours, we can get positive tuberculin test more than or equal to 10 mm in duration. It is very suggestive of TB infection in patients that haven't received BCG vaccine. Negative tuberculin test usually excludes TB, but we have false negative results in cortisone therapy, immunocompromised patients, improper technique, pre-immune phase, as it takes 2 to 10 weeks after tuberculosis infection for an immune response to PPD to develop, fulminant tuberculosis, especially miliary TB. Invasive methods: pleural aspiration or bronchoscopy with BAL, bronchoalveolar lavage. Blood examination: increased ESR, normocytic normochromic anemia may be present, especially in miliary TB. Renal and liver function tests, gift and lift. Differential diagnosis: TB enters in differential diagnosis for almost all chest diseases, but especially we have bronchogenic carcinoma, pneumonia, other causes of hemoptysis, and fever of unknown origin. Treatment, which is the most important thing in this chapter: prevention of TB and therapeutic treatment. Prevention of TB is divided into 2 subtitles: increasing host defense and prevention of infection. Increasing the host defense by good nutrition, good housing, good sleep, BCG vaccine for whole community, INH for contacts. Prevention of infection: for milk, pasteurization of milk; for sputum, case finding, isolation, and proper treatment. Therapeutic treatment: we have general and specific treatment. General: reassurance, rehabilitation, follow-up after healing for a period of 5 years, bed rest until the activity of the disease is controlled. Prolonged bed rest is not essential. Specific treatment: anti-tuberculous drugs. And we need to discuss main principles, the drugs, regimens, treatment in special situations, and TB and cortisone. The main principles: continuous combined, proper dose, prolonged periods from 6 to 9 months or more. Pyridoxine, vitamin B6, should be administered with INH, is mandatory to prevent peripheral neuropathy. The drugs. Drugs are classified into standard first line and reserved second line. The standard drugs: rifampicin, ethambutol, streptomycin, pyridinamide, and INH, isonicotinic acid hydrazide, or isoniazide. If we're going to talk about the doses, it's 5, 10, 15, 20, 25, 30. I didn't make this. Dr. Mowafy made it. INH from 5 to 10 milligram per kilo per day orally. Its side effects are idiosyncrasy, neuropathy, hepatotoxicity. Same letters of INH, idiosyncrasy, neuropathy, and hepatotoxicity. Rifampicin, 10 to 15 milligram per kilo per day orally, hepatotoxic and GIT irritation. Streptomycin, 15 to 20 milligram per kilo per day intramuscular, ototoxic and nephrotoxic. Ethambutol, 20 to 25 milligram per kilo per day orally, and it causes optic neuritis. Pyridinamide, 25 to 30 milligram per kilo per day orally, it causes hepatotoxicity and gout. Reserved drugs, second-line treatment, capromycin and kanamycin are nephrotoxic and ototoxic. Biomycin, para-aminosalicylic acid, cycloserine causes headache and psychosis, ciprofloxacin and ofloxacin. Regimens, 6 to 9 month continuous regimen. The initial phase is 2 months of 3 and 4 drugs, rifampicin plus INH plus 1 or 2 drugs from the standard drugs. Continuation phase from 4 to 7 months of rifampicin and INH. Treatment of TB in special situations, renal failure, rifampicin is the safest drug to be used, and streptomycin and ethambutol are contraindicated, but the rest of the standard drugs can be used during renal failure. So we need to know rifampicin is the safest, while streptomycin and ethambutol are contraindicated. Then we have during pregnancy, INH and ethambutol can be used. Liver cell failure, rifampicin and pyridinamide are contraindicated, while streptomycin, INH, and ethambutol are used. TB and cortisone. Cortisone may be used carefully in some cases. TB meningitis, lymph node enlargement, genitourinary tuberculosis to prevent ureteric strictures, pericarditis, peritonitis, and pleural effusion to prevent fibrosis. Surgery in tuberculosis. Pleuropulmonary resections in resistant cases, but the role of surgery is limited nowadays due to the effective chemotherapeutic agents. Prognosis of TB. Almost all properly treated patients with TB can be cured. Relapse rates are less than 5% with current regimens. Extrapulmonary TB can be pleural TB, tuberculous pericarditis, TB peritonitis and ascites, GIT tuberculosis. The ileocecal area and the jejunum are the commonest sites. The clinical picture is abdominal pain, diarrhea, and palpable abdominal mass. Bone and joint TB, genitourinary tract TB, CNS TB, cutaneous TB, ocular tuberculosis, such as choroidal tuberculosis that can be found in miliary TB, adrenal gland, and in the form of Addison disease. And this concludes our chapter of TB. Lung cancer. Risk factors. Cigarette smoking, the most important single factor. Smokers are 15 times more liable to develop lung cancer compared to non-smokers. Passive smokers are 2 times more liable. Stopping smoking decreases the risk, but the risk remains higher in people who have never smoked before. Air pollution from motor vehicles, factory emission, coal burning. Occupational factors, asbestos exposure, arsenic and heavy metal exposure. Lung lesions. Old fibrosis, as in TB, may result in scar carcinoma or COD, which is the most important risk factor in lung lesions. Genetic factor may play a role. Diet, low vitamin A and C, increases the risk of lung cancer. Pathology. WHO classification. We have squamous cell carcinoma, small cell carcinoma or oat cell carcinoma, adenocarcinoma, large cell carcinoma, and others such as pulmonary lymphoma, carcinoid, and sarcoma. Squamous cell carcinoma, it's central, with incidence 35%. Small cell carcinoma, central, 20%. Adenocarcinoma and large cell carcinoma are peripheral, with adenocarcinoma of incidence 30%, while large cell carcinoma is 10%. Pulmonary lymphoma, carcinoid, and sarcoma, others carcinoma of lung, central or peripheral, with incidence 5%. Spread, local spread or hematogenous spread, lymphatic spread, local spread to pleura in peripheral types, leading to pleural manifestations, to mediastinum in central types, leading to mediastinal syndrome. Hematogenous spread, lung, liver, bones, liver, bones, brain without the last L of lung, especially in small cell carcinoma, the brain. Lymphatic spread to hilar, mediastinal, axillary, cervical lymph nodes. Clinical picture, the patient is usually elderly male, chronic heavy smoker, may present with the following symptoms. Intrathoracic manifestations, extrathoracic manifestations. The intrathoracic manifestations are divided into bronchopulmonary, pleural, and mediastinal. Mediastinal, cough, dysphagia, hoarseness of voice, dyspnea. Pleural manifestations, dry pleurisy may occur, malignant effusion, massive hemorrhagic, rapidly accumulating, transudate due to compression of azygous vein, chylous effusion due to obstruction of thoracic duct, empyema due to rupture of malignant abscess into the pleura. Then the bronchopulmonary presentations. Asymptomatic in 1/4 of the patients, without any symptoms at the time of diagnosis, detected accidentally on routine X-ray as coin shadow in the lung. Primary tumor symptoms, cough, expectoration, dyspnea, chest pain, hemoptysis in the form of blood-tinged sputum, or rarely red currant jelly sputum, bronchial obstruction, partial or complete collapse, partial emphysema, bronchiectasis, pneumonia, usually recurrent at the same site, lung abscess due to secondary infection, necrosis of the tumor itself, thoracic inlet syndrome or superior sulcus syndrome due to Pancoast tumor. Pancoast tumor is a tumor occupying the apex of one lung, invading 2 bones, 2 nerves, and 2 blood vessels. 2 bones, upper 2 ribs, 2 nerves, sympathetic chain, lower trunk of brachial plexus. Sympathetic chain will cause Horner's syndrome, ptosis, meiosis, anhidrosis, and flush with enophthalmos. Lower trunk of brachial plexus, pain along the medial aspect of the arm with wasting of the small muscles of the hand. 2 blood vessels, superior vena cava and subclavian artery. Subclavian artery will cause unequal pulse in both upper limbs, while superior vena cava obstruction will lead to non-pulsating congested neck veins. Then we have the extrathoracic manifestations. They are divided into metastatic and non-metastatic. The metastatic manifestations: liver, jaundice, palpable tender liver mass, bone pain, pathological fracture, brain, polyneuropathy, myopathy, paralysis, paresis, heart, arrhythmia, and pericardial effusion. Non-metastatic manifestations or paramalignant syndrome, they are mostly common with small cell carcinoma. Endocrinal, due to production of abnormal metabolites such as ectopic ACTH secretion will lead to Cushing, and parathyroid hormone-related peptide secretion will lead to hypercalcemia. Inappropriate secretion of ADH will lead to hyponatremia and gynecomastia. Neurological, polyneuropathy, myopathy, myasthenia, Eaton-Lambert syndrome. Hematological, thromboembolic manifestations, anemia, leukemoid reaction, skin, dermatomyositis, acanthosis nigricans. Others, cachexia, clubbing, and hypertrophic pulmonary osteoarthropathy, which are more common in squamous and adenocarcinoma. Bronchuria, excessive production, more than 100 ml per day of watery sputum. Alveolar cell carcinoma, bronchoalveolar carcinoma is a subtype of adenocarcinoma, not associated with smoking, but it can present with bronchuria. Very important MCQ note. Investigations: radiology, sputum, invasive, blood, and metastasis. Metastasis, abdominal ultrasound, bone scan, brain CT, blood examination, Kift and Lift, serum electrolytes, increased ESR. Invasive methods: bronchoscopy with BAL, positive, especially in central types, transthoracic needle aspiration for biopsy from peripheral lung lesions, and pleural aspiration, sputum for malignant cells. And lung carcinoma, which is most commonly associated with hypercalcemia, is squamous cell carcinoma. So we need to know squamous cell carcinoma may have hypercalcemia, clubbing, and hypertrophic pulmonary osteoarthropathy. Radiology: chest X-ray may show coin shadow in the lung, area of collapse, consolidation, lung abscess, mediastinal mass, pleural effusion, rib erosion, hilar lymph node enlargement, and elevated diaphragm. CT chest for accurate localization and evaluation of lymph node for staging. Differential diagnosis: pulmonary infarction, benign tumors, TB, pneumonia, lung abscess, other causes of pleural effusion, and other causes of mediastinal syndrome. Staging gives prognostic information and guide treatment decision: small cell lung cancer, divided into limited and extensive. The limited is confined to ipsilateral hemithorax and supraclavicular lymph nodes. Non-small lung cancer classified by T and M staging. MX cannot be assessed, M0 distant metastasis, M1 distant metastasis. Regional lymph nodes, the N and X cannot be assessed, N0 no regional lymph node metastasis, N1 ipsilateral, peribronchial and or ipsilateral hilar lymph nodes, N2 ipsilateral mediastinal and or subcarinal lymph nodes, N3 contralateral hilar mediastinal or N-scalene or supraclavicular lymph nodes. Extent of primary tumor, the T, TX, the primary tumor cannot be assessed, or tumor is proven by malignant cells in the sputum without any visualization by imaging or bronchoscopy. T0 is no evidence of primary tumor. TIS, tumor in situ. T1, tumor less than 3 cm surrounded by lung or visceral pleura without bronchoscopic evidence of invasion more proximal than the lobar bronchus. T3, tumor is more than 3 cm invading visceral pleura or main bronchus, 2 cm, more than 2 cm distal to carina. T3, tumor of any size invading chest wall, diaphragm, parietal pericardium, mediastinal pleura, or tumor in the main bronchus less than 2 cm distal to carina. T4, tumor of any size invading heart, great vessels, trachea, esophagus, carina, vertebral body, or malignant pleura, or pericardial effusion. The stage grouping: Stage 0, tumor in situ. Stage 4, any T, any M with M1. Then we're gonna go to the hard part. Stage 1A, T1 and 0, M0. 1B, T2 and 0, M0. 2A, T1 and 1, M0. 2B, T2 and 1, M0. T3 and 0, M0. 3A, T3 and 1 or 2, M0. T1 and 2, M0. T2 and 2, M0. 3B, T4 with any N and M0. 3B, any T and 3, M0. Treatment: surgical resection is the treatment of choice of patients with non-small cell carcinoma. The criteria for operability: good lung functions, no metastasis, tumor is confined to the lung and away from carina by more than 2 cm. Contraindications to surgery: distant metastasis, mediastinum invasion, malignant pleural effusion, severe cardiac or other medical problems. Radiotherapy less effective than surgery. Chemotherapy: cisplatin-based chemotherapy, especially for small cell carcinoma, using combination of cytotoxic drugs, sometimes in combination with radiotherapy. Symptomatic treatment for pain relief. Treatment of non-small cell lung cancer according to the stage. Stage 1, complete surgical resection. Stage 2, resection with radiotherapy. 3A, resection, radiotherapy and chemo. 3B, chemo and radio, but it's inoperable. Stage 4, cisplatin-based chemotherapy. Treatment of small cell lung cancer, it's chemosensitive. The major problem is presence of distant metastasis. Surgery has no role except insulatory pulmonary nodule without any evidence of metastasis, and it's rare. Combination chemotherapy, cisplatin, cyclophosphamide, is used for limited and extensive small cell carcinoma. Bronchial adenoma or carcinoid tumor, locally malignant, highly vascular tumor originating from endocrine cells, and it has 2 pathological types, pedunculated and sessile. The clinical picture is hemoptysis, bronchial obstruction, carcinoid syndrome, and associated with Cushing syndrome due to ectopic tumor ACTH production. Hemoptysis, the most important and frequent symptoms because it's highly vascular tumor, bronchial obstruction, partial emphysema bronchiectasis, complete collapse, intermittent fleeting atelectasis. Carcinoid syndrome, attacks of flushing, hypotension, abdominal cramps, bronchospasm, diarrhea, associated with cardiac valvular lesions due to secretion of serotonin and other substance by the tumor. Investigations: X-ray may be normal, coin shadow, localized emphysema or lung abscess, fleeting atelectasis. Bronchoscopy bleeds easily, so you should be careful. Hydroxyindole acetic acid higher in urine. Was that heightened? I'm sorry. Metabolite of serotonin. This will be raised in carcinoid tumors. Differential diagnosis of bronchial adenoma. Other causes of hemoptysis with normal X-ray, TB, bronchiectasis, chronic and acute bronchitis. Causes of fleeting shadow. Lung hematoma, eosinophilia, fissural effusion, and finally, of course, bronchial adenoma. Treatment. Surgical excision of the lobe and the segment containing the tumor. Laser therapy may be used. Argon plasma coagulation. Prognosis. It's good prognosis. Pleural tumor, mesothelioma. Benign pleural mesothelioma, pleural fibroma, and malignant mesothelioma. The benign pleural mesothelioma, surgical excision is the treatment, chest X-ray, D-shaped opacity, clinical picture, space-occupying lesion with hypoglycemia. 3 words. Malignant mesothelioma, highly malignant, bad prognosis, treatment is radio and chemo with unsatisfactory results. Most commonly in men between the age of 50 and 70 years. The lesion arises from mesothelial cells of the pleura, and asbestos exposure is responsible for at least 85% of the malignant mesothelioma. Clinical picture, chest pain, dyspnea, weight loss, pleural effusion. Chest X-ray shows pleural effusion with lobulated pleural thickness. Then smoking. Smoking index, it's the average number of packs per day times number of years of smoking. And the pack has 20 cigarettes. So if the index is mild, it's up to 20, up to 40 moderate, and more than 40 is severe. We calculated by counting cigarettes per day for about times the number of years of smoking. Important terminologies: non-smoker, person who smokes less than 1 cigarette per day for 1 year, or up to 1 pack per month, or 20 packs in a lifetime. Current smoker, person in regular cigarette smoking up to 1 month ago. Ex-smoker, person who has quit smoking for at least 6 months. Passive smoker, second-hand smoker. Hazards of smoking: chest, COPD, and lung cancer. 1 cigarette contains more than 4,000 carcinogenic compounds. Cardiovascular, it increases the incidence of sudden death, coronary artery disease, malignant hypertension, platelet adhesion, aggregation, and whole body viscosity, carboxyhemoglobin, hematocrit value, heart rate, catecholamine release, and sensitivity. Morbidity from peripheral vascular diseases and mortality due to aortic aneurysm. And it decreases the level of HDL and threshold of ventricular fibrillation. Smoking accounts for 30% of all cardiovascular death. GIT. It causes peptic ulcer, cancer tongue, esophagus, stomach, cancer bladder. And in females, it causes osteoporosis, stillbirth, stunted baby growth, and congenital anomalies. Temporal sequences of events following smoking cessation. Heart rate and blood pressure return normal within 30 minutes of the last cigarette. Oxyhemoglobin and carbon monoxide levels return normal within 8 hours of the last cigarette. Nicotine level returns normal within 3 hours of the last cigarette, but with psychological craving within 3 weeks after the last cigarette. Myocardial infarction risk drops to 50% of the smoker's risk 5 years after the last cigarette, while lung cancer risk drops to 50% of the smoker's risk 10 years after the last cigarette. And this concludes our chapter for today.